for session 5, we're going to cover nerve stimulation and practical pharmacology. So, electric nerve stimulation replaces the existing mechanical stimulation, also known as elicitation of paresthesia, as the most common nerve localization technique of the past. So, it was widely started spreading around 70s and 80s when we started getting commercially available insulated needles in nerve stimulators. Even so, technique was described much earlier than that. So PNS, or peripheral nerve stimulation, was more accepted by the patients, and of course because it was more comfortable than probing with the needle until we get this paresthesia. It was also kind of more objective because now you see twitch versus relying on patient report. And if you use objective endpoint, you can sedate patient more generously. And it was a thought that it may be a little bit safer because with the electric stimulation, you might not need to get too close to the needle to see motor response. So why we need to learn PNS today if we have ultrasound? And there are several reasons. First, it's very helpful while learning ultrasound guided regional anesthesia to confirm correct nerve ID. So when you see some kind of white blob on the screen and you're still learning and you don't know is it nerve or some uh, connective tissue bundle or tendon, you can try to twitch it. It's add additional point beside needle tip visualization while mastering ultrasound guided needling. So while you're learning, unfortunately, you're not always seeing needle tip perfectly. So seeing a twitch means that okay, you're not seeing the tip and tip is already touching the nerve. It is helpful when ultrasound picture is suboptimal, or we have to use an unfavorable angle of incidence between needle and ultrasound plane. It's helpful when you don't have ultrasound machine, and especially it's helpful when you place in stimulating catheter for deep block, such as deep sciatic or lumbar plexus block, or it's difficult epidural, because stimulation allows to decrease secondary block failure. There's also a notion that it might add extra safety to avoid inadvertent intraneural needle placement when you see it reach at very low current. So altogether, UGRA is great, and you can probably do good UGRA without stimulation, but there's a good place for PNS, peripheral nerve stimulation, and we're gonna learn it today. So let's start from basic electrophysiology. So this is a famous strength duration curve and introduces us to two big concepts of electrophysiology of PNS, rear base and chronoxy. So rear base is this one, because on this axis we put a current and we put it in the rear basis, and here we put duration. So there is a threshold for current that despite infinite duration, you will not be able to stimulate the nerve, will not be able to reach threshold and depolarization. And chronoxy is actually duration of this stimulation when you apply current that is equal to two rear bases. And why it's important? So because chronoxy apparently is different for different nerve fibers. So you can see this graph, right? Starting from skeletal muscle, heart, pain fibers, sensation fibers, and motor fibers. All look at this table. So you can see your A alpha, your motor fibers, right, that are big and myelinated, they have actually a short chronoxy, about 0.1 milliseconds, while your other fibers like sympathetic or autonomic preganglionic or your pain and temperature have a little bit different chronoxy. And what is the practical implication of this? It means that motor nerves, motor fibers, are more excitable, and muscle twitch will appear before stimulating sensory pain fibers. So it becomes more objective and more comfortable for patient. And another practical implication that we would use when we choose pulse duration, the modern stimulator allows us to choose pulse duration. We would use pulse duration close to particular fiber's chronoxy. And as we said, for motor fibers, 0.1 milliseconds. While if we try to stimulate pure sensory nerve, let's say lateral obtunious, we need to increase pulse duration. And we'll talk about this later. So another important concept of PNS is needle to nerve distance. And this is our simplified formula. So current threshold that will cause depolarization would be equal, or depends, let's say depends on distance of the needle tip to the nerve. And this distance is squared, reverse squared. So basically this minimal current needed to depolarize the nerve is directly proportional to square of the distance from the nerve. And this is kind of a picture to illustrate this. So this is we are in contact with the nerve, so distance is 0 millimeters, and you need very little current. And here we're far away, we are more than probably 8 millimeters, and we need much higher current to depolarize this nerve. Again, it's very important that we're talking about, when we're talking about this current, right, we're talking about total charge, right, total charge, number of these electrons. And total charge is the product of set amplitude and impulse duration. So for example, if you increase your impulse duration from 0.1 to 0.3, you may need much less amplitude to depolarize this nerve. And it's kind of important when you compare, papers, scientific papers. So next, what is important to understand is this kind of imagine this electric field on the tip of the needle, if we're talking about insulated needle, and understand there's a particular three-dimensional distribution, right? We call it electric field. We're looking at this plane and in a lateral view. And this electric field, its density, and density represented, more dense lines here, right? And its shape, right? See shapes here versus shape here, and this different, will depend on needle design, on a gauge, bevel type, length, type of insulation, and this is a good example. So here is an uninsulated needle, so needle, and we see that it requires much higher current, right? Here we see these numbers, than insulated needle with very compact and much denser electric field. And also I want to point out that this particular shape of electric field is not as we perfectly imagine here, right? Like a little teardrop on the tip of the needle. It could be asymmetrical, and this asymmetrical electric field explains why sometimes just rotating needle will bring about the twitch without moving needle back and forth, right? So let's go to next slide. Uninsulated needles and Rush test. So when Rush is one of the pioneers of regional anesthesia, right? When he was using PNS for nerve localization, he didn't have insulated needles, right? And so for him, it was important to distinguish perfect contact between needle tip and nerve, or accidental stimulating nerve by the shaft. You see there's some electric field here, so if there is a nerve here, he could still stimulate the nerve, especially knowing that we use much higher current when we use uninsulated needle. So he came up with this Rush test. The Rush test was injecting little test dose before full bolus. And before he would inject this test dose, he would lower current down until he hardly sees a twitch. And the idea was when he inject just few ml, twitch will disappear. And he thought that if nerve is in front of the tip of the needle, by injecting local, he would increase the distance, and that will be now we will current will be below the threshold, and twitch dissipate, right? While if he would inject and twitch doesn't disappear, then he probably stimulates the nerve with a shaft. So it's not entirely true, and I'll explain you why. And then basically these tests become antiquated because now we use only insulated needles, and we don't have this issue. On top of it, later on, it was confirmed that rush test is explained not by pushing nerve away and increasing the distance, but exactly affecting this density of electric field. And it happens when you inject solution like local anesthetic or saline that conduct electricity, because injecting solution with as it conduct electricity will immediately decrease the density of electric field. The density is represented how tightly those iso lines are positioned here. And as a confirmation of this concept is a Tsui test. So when you inject dextrose, you frequently will reinstate twitch because dextrose does not conduct electricity, and it will densify the electric field on the tip of the needle. So let's talk about some practical issues. Polarity. So usually you don't have to think about it if you use a commercial needles and stimulator, but if you're trying to kind of make shift it yourself, you have to understand that needle is negative, N, right? It is so-called cathodal stimulation. And then return electrode, usually red for commercial stimulators, is positive and could be in any place, honestly. And that's kind of a demonstration because of a normal membrane, transmembrane potential. It shows you why cathodal stimulation is much more effective. As a matter of fact, it requires only 25% of energy compared to anodal stimulation. This is a sign of anodal stimulation. So let's talk to actual practical issues. So first of all, in order for nerve stimulation work, you have to make sure that patient is not chemically paralyzed. It happens still. People come to do block and cannot get a twitch because they forgot that muscle relaxant were injected. You need at least 2 out of 4 recovery of twitches on train of 4 if you decide to place continuous stimulating catheter at the end of a case or after induction of general anesthesia. Second point, circuit should be completed, and that's why we have this little light here, and we have a sound, right? The sound will change the pitch, and light will go from red to green when circuit is complete, and vice versa. Another point, the modern stimulators, this is here, impedance, the resistance, is a constant, output device. So whatever you set with your dial, this is dials that you're going to use, will be maintained despite different tissue resistance. But sometimes it takes like few, microseconds, seconds before it's adjusted. So kind of be patient and give some time for full adjustment. So now, practically, what do we do with our stimulator? We'll set our amplitude, and this is dial that we use to set amplitude, to 1 or maybe 1.5 milliamps. It's right here. So right now it's only 0.3 milliamps. Then we set our duration. So right here, we click this button and now dial this one. And in this case, duration is 0.1 milliseconds. And then we click this button and adjust again by dial and set 2 Hertz. If you change the frequency to 1 Hertz, it will slow down your needle movement. You have to move your needle very slowly around the nerve, otherwise you're gonna you have a risk of missing nerve because you're gonna pass the nerve between delivering impulses. So if we dealing with neuropathic nerve, let's say patient with bad diabetes, then we need to increase duration of our impulse. So instead of 0.1, maybe 0.3 or maybe even 1 millisecond. So this particular machine allow you 0.1, 0.3, and 1 millisecond. Some other machine give a higher range of duration. And we have to increase intensity or amplitude. So maybe instead of 1.5 milliamps, maybe 2 milliamps, maybe 2.5, and so on. For locating or confirming pure sensory nerve, like for example, a lot of hemocutaneous or saphenous nerve, by so-called eliciting electric paresthesia, we also need to use longer duration of impulse. And this machine is not appropriate, but if you planning to use transcutaneous mapping, so you're going to stimulate those nerves through the skin, then amplitude that's required for this could be need to be much higher, up to 20 milliamps, and I'll show you it a little bit later. So how do you do it practically? So this is a, what we call old school surface landmark and PNS technique. This is sciatic. We outline our landmarks and advance the needle with initial settings right here, 1.5, 0.1, 2 hertz, and slowly advance needle toward the sciatic nerve. It might take a couple passes, but eventually when needle gets close, we're gonna see it twitch. When you start seeing twitch, we'll start dialing our amplitude down. And the idea is, if we still have visible twitch with current at 0.5 and below, right, then we are very, very close to the nerve. So 0.5 is usually about less than 5 millimeters distant to the nerve, and then we can inject the total dose of local anesthetic. So remember, I mentioned that some people use peripheral nerve stimulator not to localize the nerve, right? They use ultrasound to localize the nerve, but use peripheral nerve stimulator to rule out the fact that needle is within a nerve. So unfortunately, the sensitivity of this is very limited. But specificity of intraneural placement with very low current, when you have a brisk switch at less than 0.2 milliamps and 100 or 0.1 milliseconds, then it's very specific that you are intraneural. But unfortunately, you could be intraneural even if you are between 0.2 and 0.5, and even a higher number. So it's not sensitive, but very specific. And some people keep nerve stimulator, at somewhat 0.5, don't dial it down. But then, if they have a twitch, despite the fact that it looks like they're outside of the nerve, they would start dialing down. And if its twitch is still there at less than 0.2, they would pull needle out a little bit to avoid injecting intraneurally. So common question is why this motor twitch is not always a perfect surrogate marker for peripheral nerve blocks, right? Especially because our goal is actually pain control. And I think this is a nice quotation from one of the anatomical studies. But in a sciatic nerve of the rat, for example, there's 27,000 axons. Only 6% of them are motor axons. Remaining 23% are myelinated sensory and 48 are unmyelinated sensory. And there are also 23% of sympathetic axons. On top of it, we have a lot of stroma, and the more distally we go, the more of stroma and connective tissues ratio with the actual neural tissue. I'm talking about axons. So that will explain, especially if we have this, electric field that is a little bit asymmetrical, when we could be quite close, but still do not see actually motor twitch. And it not necessarily will translate in a fail block, because again, the goal is to block our sensory fibers, right, and pain fibers. All right, so this is a little summary about peripheral nerve stimulation and the relationship between our current and twitch. Again, to repeat, the threshold current is proportional to the distance and a base square law, but this is not very sensitive, not very specific. And when you have a low current, it's predicted you that very close, 1-2 millimeters. And when you less than 0.2, you're very likely inside the nerve. But at the same time, you can be intraneurally even if you have current 0.5, and sometimes you might have no motor response despite the fact your needle is intraneurally. On top of it, that's kind of important, needle trauma can create edema or introduce blood. And remember, both of those will dissipate electric field, right? Because they're conductive solutions. And this will decrease your current density, and you might need to you have to raise up your stimulating threshold. So that's another stimulator I was mentioning before. This one allow you transcutaneous mapping, and because of that, it can go much higher on the amplitude of your impulse, and that would be important if you planning to perform epidural stimulation. We'll have a separate lecture on that. Also, if you see the benefits, the duration of impulse can vary from 0.05, 0.1, 0.1, 0.2, 0.3, 0.5, and all the way to 1 millisecond. Okay, and so now we're going to the second part of the lecture, basically practical pharmacology. How to choose the most appropriate local anesthetic for the block, and how to choose concentration, volume, and additive. And that's our choices. We see here our mepivacaine, different concentration, 1.5, 2%. We have our lidocaine, different concentration, 1%, 2%. Plain with epi, we see bupivacaine, 0.25, 0.5. Again, it could be plain and with epi. And we have a ropivacaine, anything from 0.2 to 0.5, 0.75, and even 1%. So this is a nice slide showing the mechanism of action of local anesthetic. Remember, it comes ionized, and unionized, uncharged form gets through the membrane and block voltage-gated sodium channels that are responsible for ablating this propagation of the impulse. And that's explained why local anesthetic will not work in acidic environment, right? Because with acidic environment we will have much less unionized form. It will be difficult to pop through the membrane, and it's explained why you need to add some bicarb if you have a lidocaine with epinephrine, for example, because those are usually much more acidic. So next, so what are the questions for? So let me wait until this voice goes away.
Thank you.
So now we're gonna talk about what are the practical questions. So there's actually a few of them. How fast onset is required for your block? How long duration is required? What of the what is the density of the block is required? Is it surgical block with deep relaxation versus just analgesic, motor sparing block? And question about toxicity and cost issues. So what is on the menu? So practically it's actually only two groups of amides. We hardly ever use esters, local anesthetic, for peripheral nerve blocks. So we have an intermediate duration group. It will be mepivacaine and lidocaine, and prolonged duration. Bupivacaine, levobupivacaine, and ropivacaine. So let's start from mepivacaine and lidocaine. So for practical purposes, those two local anesthetic will be considered somewhat identical for peripheral nerve blocks. They provide fast onset, about 15 minutes after delivering local anesthetic, and last about 2 to 4 hours, sometimes 5 to 6 if you're talking about lower extremity blocks. They may produce slightly higher success rate compared to bupivacaine and ropivacaine for surgical blocks for novices. So when you start doing blocks, it probably makes sense to use those drugs to provide higher success rate for surgical blocks. Usual volumes that we use about 20-30 ml, depends on concentration. So high concentration and adding epi may expedite onset and density of the block. Epi only is added to lidocaine, but not mepivacaine, because basically mepivacaine is like lidocaine with epi. Epi slightly prolongs the block duration and allow to use more local anesthetic, right? We remember if we use Lido with epi, it's 7 milligram per kilo versus Lido, plain Lido, 4 milligram per kilo. But again, as we talked about maximum recommended dose in our last lecture, local anesthetic systemic toxicity, It all depends on the type of block because absorption is very different, from intercostal compartment versus, sciatic. Um, so adding bicarb to commercial vials of LIDA right here with epi may speed up onset, because if you look at pH on this bottle, it will be quite low. It will be about 4. And there's no need to add bicarb if you freshly add epi in a plain lidocaine. As we said, doses we mentioned 4 and 7. There's a new data, kind of exciting data, suggests that mepivacaine may have less rebound than other local anesthetic, but this is still quite new and needs some confirmation. So next, we're going to talk about long-lasting medication: bupivacaine, levobupivacaine, and ropivacaine. Again, those 3 local anesthetic are also very similar. Onset is much slower, 20 to 30 minutes, up to 45 minutes for sciatic blocks, for example. Again, high concentration may speed up onset, and 0.75 ropivacaine or even 1% ropivacaine is as quick as LIDA, or maybe even quicker if you use 1%. Bupivacaine is the most toxic from all of them. If we accidentally push high dose of bupivacaine intravascular, it's frequently deadly cardiac toxicity, and it's very difficult to treat. But also, bupivacaine is the cheapest. Bupivacaine provides the longest duration, 16, sometimes 24 hours, especially in low extremity blocks. Clonidine will prolong effect of bupivacaine, but not ropivacaine. We use 0.25% bupivacaine for analgesia and 0.5% for surgical blocks. Levobupivacaine is supposed to be slightly less cardiac toxicity, because remember, bupivacaine, it's a racemic mixture of left and right forms, and levo is the only left form and apparently has a less cardiotoxic effect. Again, I never worked with levobupivacaine in my life. I have no experience about it. Ropivacaine lasts slightly shorter than bupivacaine. We're talking about 8, 12, sometimes 18 hours, but also slightly safer and 6 times more expensive. 0.75 ropivacaine is equipotent to 0.5 bupivacaine. So ropivacaine is kind of weaker. But still, even in equipotent doses, ropivacaine is less toxic, but still could be deadly. If you have a intravascular injection of concentrated ropivacaine in sufficient amount, you're gonna have a bad last, including cardiotoxicity. We use 0.5% ropivacaine for surgical blocks and 0.2% for analgesic blocks, and it works very good. Ropivacaine provides some vasoconstriction, so no need to add epi, while bupivacaine may slightly benefit from epi. But again, we'll talk about epi separately. We don't add epi routinely at all. For both ropivacaine and bupivacaine, recommended maximal dose is about 2.5 per kilo. And again, of course, it depends on the type of a block. And both of those medications widely used for continuous infusion, and when we use continuous infusion, it will be 0.2, 0.1% concentration. And again, one more number to remember for ropivacaine is about 800 milligram for adult over 24 hours. So what about mixing lido or mepivacaine and bupivacaine to get the best of both worlds, quick onset and long duration? So unfortunately, and it's been documented several times by good studies, mixing result in average but not the best of 2 worlds. So we have somewhat quicker onset of action and significantly shorter duration than bupivacaine, but not as quick onset as lidocaine. So what is the solution if we really need those best of 2 worlds? So I think the first is just bring patient early. Bring patient and do your block at least 30 minutes before surgery. Allow you block set up, allow you to assess your block, and if you need to rescue if needed. If you really against the wall, use 0.75% ropivacaine for quick setup. As I said, as quick as LIDA. You can use different local anesthetic for different nerves approach. So for example, you can use mepivacaine for infraclavicular approach for brachial plexus for surgery, but then put bupivacaine on nerves or forearms for prolonged postoperative analgesia. But please do not use production pressure as a reason for intraneural injection. Because indeed, if you do intraneural injection, block will set up fast, but then it also at the cost of possible nerve injury. Again, another kind of a little trick, if you are good with your needle and what I call painting, if you create a donut of local anesthetic around the nerve, that will expedite onset compared to depositing the local anesthetic only on one side only. So now, a common question from junior people: when you mix two different local anesthetic, you have to remember that total dose is additive, so you have to convert to volume, and that will ease your calculation. So for example, you're gonna use 10 ml of lighter plus 10 ml of bupivacaine in typical concentration if you decided to mix it. As I said, it's really no reason to do it. And occasionally, maybe there is an excuse to switch to less toxic, let's say chloroprocaine, that will last about 90 minutes because it's probably the least toxic local anesthetic available. For rescue blocks, when bupivacaine used, and we're concerned about reaching toxic dose. So now, next move to next topic, our adjuvants. So first, and usually adjuvants are added to prolong the block. So first, always use systemic multimodal. And then if you really need long-lasting block, consider continuous nerve blocks, continuous catheter. So this table talking about best analgesic adjuvants that are added to local anesthetics, right? And we have 3 applications here, or 4: perineural, intravenous regional or beer block, intra-articular, and local infiltration. And so we will focus here. And so I put 3 slides from a review on additive to local anesthetic. You can slowly kind of look through the tables, talk about criteria for inclusion and quality, and nice quick summary and recommendation. So buprenorphine, definitely prolonged block, but at the cost of nausea. So you have to consider multimodal anti-nausea prophylaxis. We also don't have buprenorphine that easily available, and it's expensive, so it's kind of a not common practice for us. You can read more from fentanyl on your own. Next one, dexamethasone. This is the most common additive that we use. We use somewhat about 4 milligram per block, but dose is not really established. Maybe as low as 1 milligram is enough, or maybe even better than 4. Its future studies will show. And it definitely prolonged effect. But there's a controversy: is this analgesic effect is similar with systemic dexamethasone? But because risk is so minimal and we have preservative-free dexamethasone, we add it to our nerve blocks. We never use tramadol. Magnesium causes nausea, but there's some promising results on the femoral nerve block. You can read this a little bit more. Next one, epinephrine. I will talk about epinephrine, dedicated separate slide to this, but I want to point out that the prolongation is minimal here, 45-60 minutes. It prolongs a little bit, intermediate lasting and long lasting local anesthetic. Does not do much for bupivacaine, but that's important. Avoid use patients with pre-existing neurovascular compromise, like such as diabetic neuropathy, and a lot of our patients do have that, so we hardly ever use epinephrine as an additive, with maybe exception of dosing of our epidurals. Clonidine does improve, especially with bupivacaine duration, but can cause hypertension, bradycardia, and sedation. And Presidex, another new kind of a ketone block, also pretty consistent, does help, but also can cause bradycardia and sedation. Less expensive than it used to be, so some people use more and more. So, like in conclusion, practically those 2 drugs, Presidex and dexamethasone, that probably have some role. But as I said, if you use multimodal, and if it will work great, and if it's really expected to have a severe pain, just put a catheter. So let's talk about epinephrine as an additive. So originally, when we used PNS and surface landmark, adding epi to local anesthetic was adding additional safety, because epi is served as a marker for inadvertent intravascular injection. If it happens, you will see heart rate and blood pressure will increase, and you might see, T wave. Notice T wave will go down, and so if you do it in aliquots, you can stop injecting before catastrophic loss develop. On top of it, because epi works as a vasoconstrictor, it will decrease systemic absorption of local anesthetic from a site of injection. And as a result, we may use high dose of local anesthetic because it will take a longer time to achieve this, you know, uh, Tmax, and also will be less of Cmax concentration of local anesthetic. And even if we keep the dose the same, more local anesthetic gets to the nerve before it gets washed out, right? So as a result, block sets up quicker and also is denser. And epi may slightly prolong the duration because it keeps local anesthetic, there before it washed out. But this prolongation is not very significant, so 45, 60 minutes. And it doesn't prolong ropivacaine because ropivacaine has some vasoconstriction on its own, cause some vasoconstriction on its own. So high dose of epi result in adverse systemic effect. We have elevated blood pressure, heart rate, maybe occasional arrhythmia, ischemia, anxiety. So we have to keep it kind of low. And also, that's most important, as I mentioned before, uh, epi may contribute to nerve injury due to negative effect on the blood flow within the nerve. So adding epinephrine is not recommended in patients with pre-existing nerve injury. So if you decide to add it, the dose will be probably somewhere from 2.5 to 5 mics ml. 2.5 is a little bit safer. And as I said, with UGRA, risk of intravascular injection is less and less. So epi is used much, much less. We actually do not use epi in local anesthetic at all. So thank you very much. At end of our presentation.